Okay, I hope you can see my screen well.
Yes, we can.
Okay, can you hear me well as well?
Yes.
Okay. I seem to be having unstable internet today in my house, but in case you lose me, kindly just send me a text, Kyoko. So
Right.
I'll go through obstetric imaging because we had already done that in the tutorial. So it will be, I think it will be just, we're running through it. Then if time allows, we can do the bone imaging. Okay. So obstetric imaging, we use ultrasound, as you have already seen. A low frequency probe is used. That's the 2 to 7 megahertz, what we call a curvilinear probe. MRI is also used in cases of fetal anomalies. And for example, confirming spine anomalies, as we had said. MRI can also be used for pelvimetry. So what are the indications in first trimester? We want to confirm the pregnancy. We want to localize the location of the pregnancy. Where is the gestational sac? Is it within the uterus? Is it outside? If it's outside, then it's an ectopic pregnancy. We also want to confirm viability. So is there a fetus? And does the fetus have a cardiac activity? Then we also want to detect any signs of early pregnancy. This especially happens for those mothers who come in with bleeding. So if they are bleeding, you want to make sure that all is well. So you may find the fetus is there, but it has no fetal activity, or there is no fetus at all, or the gestational sac is irregular and no fetus. So you may find those features of failure of pregnancy. You also want to determine how many fetuses are there. So is it single or is it a multiple pregnancy? And you want to assess age. You want to date the pregnancy. Other indications is in patients who've had amenorrhea. They don't know whether they're pregnant in the first place. So you want to confirm they're pregnant and then ascertain how old the pregnancy is. Other indications include pelvic pain in early pregnancy. You can have PV bleeding. Patients with unknown menstrual dates. So this happens in patients who get pregnant and they don't know, their periods are irregular, so they don't know when they're conceived. Then there are those patients who just come and tell you, I think I feel I'm pregnant. That's another indication. When the uterus is greater or smaller than the dates on clinical evaluation, so a mother tells you she's 20 weeks, you examine, you think she's less than 12 weeks, then you send the patient for ultrasound. When the pregnancy tests is positive or HCG values are increasing, so you want to, and it's not increasing in the normal manner, so you want to ascertain that it's a normal pregnancy. Then we talked about nuchal translucency. So we measure it as well in the first trimester, between 11 and 13 weeks, 6 days. In second trimester, we want to assess the fetal presentation. We want to look for cardiac activity. Again, we want to see the number of fetuses, and decide also on their chorionicity. So chorionicity, we mean if they're twin pregnant, it's a twin pregnancy. Is each twin having its own placenta? Is each twin having its own amniotic sac? So amnionicity is the number of sacs, and chorionicity is the number of placenta. So they can be in one sac, but each with its own placenta, or they can be in one sac with one placenta, or two sacs with one placenta. Okay, so you can have monochorionic, diamniotic, you can have monochorionic, monoamniotic, so whichever arrangement. Then you want to assess the amniotic fluid in the second trimester. Remember, in first trimester, we don't do amniotic fluid index. Then you want to see how the placenta looks like and the location of that placenta. And then we do basic fetal anatomy. So the basic fetal anatomy is done between 18 to 20 weeks, to 22 weeks generally, between 18 and 22 weeks. Standard practice, 20 weeks. Normally we book the mothers for 20 weeks, but anywhere between 18 to 22 weeks is acceptable. What do we assess when they come for the fetal anomaly scan? We want to assess from the cranium. So you assess the brain itself. Are there any brain anomalies, hydrocephalus, hydranencephaly? You want to assess the presence of all the intracranial structures that are accessible at that time. You want to look at the formation of the brain itself. Are there any anencephaly, all those anomalies that you can find in the brain. Then we come to the spine. You want to assess your spine, make sure there are no spina bifida or any variation of it. Then you want to assess the face. So on the face, we want to look at the cleft palate, whether there's any cleft in the palate or in the nose, nasal clefts or palatal clefts. Then you want to assess, after you have looked at the face and you've ascertained there are no anomalies there, then you come down to the thorax, to the chest. So you want to assess the heart. Is it in the normal position? Does it have 4 chambers? Then you want to assess the lungs. Are the lungs present? Are they normal sized? Are they in the normal position? Because you can also have, for example, a heart that is outside the thoracic cavity, okay? So you want to assess the thoracic contents. Are they in the normal position, normal size? Then you come down to the abdomen. You look at the abdominal structures. You want to rule out things like omphalocele, gastroschisis. You want to see presence of both kidneys. You want to assess the bladder of the fetus. Because sometimes you are actually able to see a fetus that has like obstruction, urinary tract obstruction. So they have hydronephrosis and they will have a distended bladder. Kyoko, I'm seeing time left is 9 minutes, 49 seconds. Are we right?
Yeah, we will have to rejoin with the same link after it expires.
Okay, how many minutes was the link?
Around 45.
Okay. Next time you can just add it up to 1 hour. Please, you always have an option of signing up and getting a 1 hour. Okay, fine. We'll rejoin, no worries. So we've said you can assess the fetal kidneys, assess the bladder, assess the abdominal structures. Are they intra-abdominal? And then whether those structures are present, such as the kidneys. And then we also look at something we call the double bubble. Make sure you don't have the double bubble sign, whereby you are having a distended duodenum and a distended stomach because of a duodenal stenosis. Okay, so it gives you the double bubble sign. So you want to rule out that you're not having any stenosis in the GI. And finally, you want to look at the fetal limbs. So you are looking at the hands, you're looking at the legs. You want to make sure the bones are there, because you can find fetuses with one normal limb and the other limb is a short limb. So you assess all the limbs. Okay. Then, and finally, you also assess the adnexa in these patients. Okay, look at your ovaries, look at if there's anything in the adnexa. Third trimester, well, we are looking at the most important thing in the third trimester is we want to assess the weight of the baby in preparation for delivery. We will check for fetal cardiac activity throughout all the trimesters. You want to check for viability. You want to assess the fetal size. So we said we use head circumference, abdominal circumference, biparietal diameter, and the femur length to estimate weight. Then you want to assess how is the fetus lying. Is it in a cephalic presentation? Is it in breech presentation? Is it in a transverse lie? You want to inform the clinician the position of the fetus. Would still, as much as in third trimester, it's not the best time to assess fetal anatomy, would still do a gross assessment. So we still look at the spine, look at the limbs, just a gross assessment, but not detailed like in second trimester. You want to localize your placenta. Remember, some patients may also be having placenta previa. So you want to make sure that the placenta is in the right position, that it will not interfere with delivery. We want to do amniotic fluid assessment. And amniotic fluid, what is the normal amniotic fluid? Who should I ask? Sadi, is he in this class? Chelsea, what's the normal amniotic fluid index?
She's not in.
Okay, so how many are you in this class today? 9. So everyone is not in. There are some people who are not in the class. Okay, Angela, what's the normal AFI? Anybody knows the answer? Musungu?
I think 8 to 25. I would say also
Okay.
5 to 25 centimeters.
Okay. So both figures are acceptable. However, in radiology, between 5 to 8, we normally say that is mild oligohydramnios. So we want to watch out for that patient who has 5 to 8. So we consider 8 to 25 normal. Anything above 25 is polyhydramnios. Anything less than 8 is oligohydramnios. So we normally grade the oligohydramnios. So less than 2 is severe oligohydramnios. 2 to 5 is moderate, and 5 to 8 is mild oligohydramnios. Okay. And that is how the curvilinear probe looks like. Maybe I'll take a photo tomorrow with one of you who has manicured nails. Then we can have it for this presentation for future use. Okay, so this is the fetal head. So when you're taking the biparietal diameter, we want to take it from the outer aspect of this bone to the inner aspect. Okay, unfortunately, I don't have the nice inner aspect, but the inner aspect on the contralateral side, cutting through the thalamus. This is the level of the thalamus of the fetal brain. So we assess the structures. When you're looking at it, we want to see that the falx is present, and this is the cerebellum right behind here. These are our choroid plexuses, these two white things here. Okay, and then a bit of the ventricles is seen here. Okay, then this is the abdomen. So you check abdominal circumference, the entire outer margin. So you take the circumference on the outer margin. So at what level do we do abdominal circumference? We do at the level whereby we see the stomach bubble, where we are seeing the umbilical vein, and we also have our spine, the fetal spine. So that's the level where we do the abdominal circumference. And finally, we do the femur length. The femur length, we take it from that margin to the other margin. Okay. Any questions? So it wasn't going to be detailed because we've already done it in class. So I think I just wanted to make sure we have gone through everything we discussed. Any question?
Daktari, just a clarification.
Yes.
About the femur length. You said from which particular anatomical site to which particular anatomical site?
So we take the entire length of the femur. When you're imaging, you'll see the femur from one end to the other. So you take the entire length. Yeah.
Okay. Asante.
Could you please repeat the landmarks for abdominal circumference?
So for the abdominal circumference, you want to be seeing the umbilical. Sorry, you want to be seeing your stomach, the stomach bubble. Sorry, I'm just trying to move back up to that image. So this would be our stomach bubble for this fetus. You want to be seeing your spine. Okay. And you want to be seeing the umbilical vein. Okay, so it's actually a continuation of the umbilical vein into the portal vein of the fetus, into the liver of the fetus. Okay.
Okay, thank you.
Any other question? We have 1
Yes.
minute left.
Yes, in terms of the head circumference, there was a thing to do with the septum pellucidum. Is it also visible on the ultrasound?
The septum pellucidum.
Yes, the septum pellucidum.
Well, yes, it is visible. So the main structure you want to find is your thalamus, so that you're having your interhemispheric fissure in between and your thalamus. Because
Okay,
if you pick the septum pellucidum, you'll be at the inferior margin of your lateral ventricles. So you'll be lower than you may not be able to get a nice, that's an axial view of the fetal head.
Okay.
So yes, you are able to see the septum pellucidum.
Okay, thank you.
Any other question? Okay, so I guess we can all log out and then log in again. Then we do is it okay we proceed with the bone imaging so that we finish this class?
Yes.
Okay. Let's do that then. We can all log out.